Hello, everyone. My name is Dr. Richard Horowitz, and we are here today with Lorraine Johnson for Doctors Talk for the Healing from Lyme Summit. It's a great pleasure to have Lorraine here today. We're going to be discussing patient-led research using the MyLymeData patient registry. For those of you who don't know Lorraine Johnson is a lawyer and CEO of LymeDisease.org, which reaches millions of Lyme patients. And LymeDisease.org has launched one of the nation's largest patient-driven research projects. It's a patient registry and research platform that allows patients to pool their data to help find a cure. And Lorraine, it's really a pleasure. You and I have not had a chance to connect for a while, so it's really great to see you. Why don't you tell people a little bit about yourself, how you got into this, right? Your story a little bit, and then let's dive into the Lyme data and the great information that you've gotten from it.
Yeah, it's great to be here with you, Rich. I came into Lyme like a lot of people do. I was a reluctant volunteer, meaning I came down with Lyme disease. And as I was going through the diagnostic process and the treatment process and finding out how difficult it was, and I had been misdiagnosed for 5 years, which I don't think is uncommon. And finally getting the treatment that I needed to get back on course, I thought, this isn't right. We really need to step in and do something for the patients. And so I joined LymeDisease.org and got on their board, and we started doing a lot of advocacy work. But then, somewhere along the line, I just figured out that you can say things that are right or that are ethical all you want. What really matters is, do you have the data? Can you back it up? Do you have solid facts? Because honestly, public policy makers, they don't want to hear about your opinions on anything. They want you to show them the data. And patients just really didn't have a way to put together data. And at the time, I was doing a lot of public speaking and engaged with a lot of large government organizations like, internationally it would have been the Cochrane collaboration, but locally it would have been the Patient-Centered Outcomes Research Institute, which was just conducting some groundbreaking research. And they had funded 35 patient registries. And so they asked me to be on their advisory committee. And then they asked me to be on their executive committee. So I was really learning from the best folks around about how to do patient-led research. And I thought, I'm going to launch a registry. So we launched the registry while I was at PCORI, and it was initially part of the Patient-Centered Research Outcomes Institute. So we were breathtakingly lucky that we had people who just sort of held our hand and tutored us until we got it launched and launched correctly. And then we were just amazed at the success for it.
Yeah, no, that's great. In fact, this is your quote. I'm attributing this to you, and I have to tell you because you just mentioned this, and I think it's an amazing quote. In God we trust, but all others bring data. And I think it is a fabulous quote because ultimately we've always known that it is big data ultimately, right? That we need to help really solve the problem, because otherwise we all see things from our own lens, but we've got to create that big data registry. So tell us exactly, what is the MyLymeData? MyLymeData, what does it do? Why is it important? What types of patients have you included? Give us a little background on it.
Well, MyLymeData, in order to be enrolled in it, you simply have to be clinically diagnosed by a clinician and be in the US. That's all we require. And so it's a really broad registry. We have people who have acute Lyme disease, people who have late untreated Lyme disease, people who have treated Lyme disease that's become chronic, 6 months or more after their initial treatment. And then we have patients who are well. So, when we launched the registry, we didn't expect to get a lot of acute patients, and we didn't expect to get a lot of well patients. But we probably have the largest registry of patients who have acute disease and also patients who are well, because they came and they filled out the questionnaire. And so now they're part of the database, which means we can compare people with acute disease to people with chronic Lyme disease, to people who are well, and find out how they differ, and how are they alike. So I think we're just really fortunate with the breadth of people who enrolled. And we have 18,000 people who've enrolled now, and it just keeps growing. So it's hard to overstate the importance of having data and vast quantities of data. So the data that we collect is both deep, meaning we ask all of the questions that you would think to ask of Lyme patients. And we do it in a way that's very credible. We use government questions to the extent that we can. So we really want to be able to compare ourselves to other diseases, to the general population, and we're able to do that because we ask the right questions. And the other thing is it's very broad. It includes all of these different types of patients. So that means that we can divide people into subgroups. We can say, how do treatment responders compare to treatment non-responders? What's different about those two groups? What was it that the responders did that made them more likely to get well? And I think everybody wants to know that. What treatments have people found to be the most effective? And that is the type of information that is not being collected it's not being collected by anybody, because nobody has that type of resource to do that. And because, clinical trials are usually very narrow. Maybe they're a convenience sample of people who walk in the door from somebody who you respect, like you've done research. And maybe it's a randomized controlled trial where you eliminate 89 to 99% of the people who applied. So then you take those results and you say, okay, well, those results are not going to apply to most patients because you excluded most patients, right? So now what are those patients to do? And what are clinicians to do? And how are we guiding people? So I think that collecting the type of data that we're able to collect allows us to do things that other resources can't do, even big data resources.
Mhm.
So if you look at, say, like an insurance database or EHR records, they're only as good as the information they collect. And the fact is that those databases are created to collect and assist in billing practices. So they don't ask the questions that you want to know. What treatments have you tried? What's been successful? So you have to have a registry that's actually vast in terms of what it's asking, and you have to have the right people working on it.
Right. No, it's excellent. And if you've told me the public policy requires data, I mean, how do you have public policy without adequate data? And I guess the question I would have is, because you have the largest database at this point than anyone has on these, acute and chronic Lyme patients, do you think it's actually moving the needle a little bit? Because I think a lot of us have been frustrated, of course, with how slow the process is, right? I was on the HHS tick-borne disease working group on the first round, Pat was there. We've all put our time in with this, and yet we look
Yes.
at how slow the process is. I mean, do you think the database is starting to move public policy a little bit in the right direction?
I really do. I mean, I think, okay, so in the tick-borne disease working group, which was initiated under the 21st Century Cures Act. So it was really, that act was intended to start engaging in innovative research. It was really intended to break open the doors of traditional slow-paced plotting research. And so that was what really sort of opened the doors for these sorts of things. And we've been able now, when we go into, say, the tick-borne disease working group, and I've been on a subcommittee for every working group, to provide information, to search our database, to make sure that they've got the tools that they need, to point them to we published 6 studies that are peer-reviewed, to point them to those studies so that they have research that they can cite. And we have been cited over 100 times by the tick-borne disease working group. And we're, by other researchers, we've been cited over 100 times. So yes, we're getting cited, we're getting noticed. In fact, the journals that publish us, we're in the top 5% of influencers in terms of those journals, in terms of what we've published. And these are different journals with different standards. I just pulled it together for the board the other day and I went, whoa, you're kidding. In the top 5%, I got an A. This registry got an A in terms of its research. So I feel really good about the reach that the articles have had and how they're being used by other advocates in the community,
Yeah.
because you have to be able to cite something. And so if somebody is working on a research project, they call me and I tell them, here's what you can cite. Here's what we've done. Here's what we know. And when it's a tick-borne disease working group, I'm typically, informing the person who's the head of the committee. Here's an approach. Here's what we've tried. Here's what we found out. Here are some items we have to raise. And it's made a difference. I mean, for example, we one of the things that I was involved in was writing a proposal that they start funding innovative research. So research using patient registries, research that's a little bit out of the box, right? And that got included, and then it got funded by the CDMRP, which is the Department of Defense's grant arm. So they proposed a grant that was essentially the innovative research concept that I had worked on in this subcommittee. So I think we're making a difference, but it's excruciatingly slow because patients they just don't have treatment options, and
Yeah.
they don't have time to wait because their life is just going by, right? So I think one of the things that really slows us down is the legacy systems of research. We enroll 36 patients or 120 patients, and we call that a study. And it is a study, and it does provide some information, but we're going so slow. And each of those studies takes 5 years to conduct. And so how are we going to get from point A to point B? And I'll give you an example. So let's say that you're talking about what are the treatment options that work for patients. And we did a study that showed that patients who are well or who are high responders, so people who are doing really well on treatment, we said, what was it that worked for you? How long were you on treatment? What type of physician was treating you? And the answer was they were on antibiotics. They were on them for a long time. They were on them for over 4 months, over 12 months. So these are not even time periods that are being included in any of the trials, right? And they were on various drugs. And the type of clinician that they were seeing that was improving their healthcare was an LLMD. So, I mean, like, you put out questions, you don't know what the answer is going to be. Sometimes you're surprised, people, I thought, for example, when we asked, are you on antibiotics, that almost all people would say yes. But the answer to that is 52% are on antibiotics. 52%. I was stunned, only 52%. And so then you wonder, well, why is it? Why, what are the factors that are getting in the way of these people being on antibiotics? And then you start looking at structural barriers to care. I can't find a physician. I've got to travel 200 miles to get to a physician. I'm on a waiting list for 6 months. Nobody will give me the diagnostic tests. I've had the tests done and they don't believe me. They're telling me it's all in my head. I'm being gaslit, right? That's a typical patient journey.
Right.
And then you flip that on its head and you say, well, what's the journey for the physician that's treating? Well, the physicians that are treating, their journey goes something like, I'm having trouble finding partnerships. I'm having trouble working in practices. I can't accept insurance because I may get sued, or I'm making it a target of myself. I may come up for charges of malpractice, right? So, so the path on both sides for physicians to provide care and for patients to receive care is just extraordinarily difficult. So patients,
we address the same things, and in fact you were on those committees. But when I was on the first round of the HHS tick-borne working group, we actually had discussed this as part of the problems of that. The patients weren't able to find care, and the doctors were afraid to give the care. And what a horrible situation that you have a worldwide epidemic where the numbers every year just keep going up and up and up, and they've created a platform where the patients can't get the care they need. The doctors are afraid to give the care. They're not trained to keep, and of course, to keep up with the medical literature on Lyme. I'm reading it an hour every morning, right before I even go into the office. I mean, it's a lot of work to keep up with it. So we did show, and I think a lot of that came from MyLymeData, that there are a lot of obstacles, and that was one of the things Congress was told about. So question for you. The MyLymeData, what exactly has it come up with? Because the controversies on why people are still sick, right? What did it show us about persistent Lyme disease, why it develops? I mean, what were the biggest factors that all of this data actually showed?
Well, I thought it was very interesting because we've been working with the data now for 9 years, going on 10, and we have a really solid team. So we have some academic researchers involved. We've got a biostatistician involved. And as we've gone through it and done, conducted these studies, and there are 6 of them, and they're on different factors. What we've found has been that there are common themes. So the biggest themes are delays in diagnosis, misdiagnosis, and co-infections. And when you look at people who have persistent Lyme disease, what you find is that they have those things in spades. And people who have acute disease, well, they don't have that going on. I mean, by definition, they were diagnosed early. They were treated early. How did they do on treatment compared to the people who were delayed in their diagnosis? So, delayed diagnosis is so common. It's about I think it's it's up near 70% of people have a delayed or misdiagnosis. And co-infections are like 60% of patients with persistent Lyme disease. So, what is it that's making it so difficult for people to get diagnosed and to get treated? Well, for diagnosis, we just have a lot of people who are being misdiagnosed with chronic fatigue, fibromyalgia, psychiatric conditions. I mean, those are like the common ones, right? So,
And long COVID, of course, now comes into play with all of it now, too.
Yeah, long COVID. Well, all these conditions all have similar, overlapping symptoms, right? And, I mean, speaking of long COVID, we're working, one of the things that arose out of the last quasi-government work that I was doing was for the National Academy of Science, Engineering, and Medicine. And they did a forum that included long COVID, ME/CFS, and persistent Lyme disease. And so here in this room, you had people from these various diseases talking about similarities, approaches people were trying, what works, what doesn't work, and the need to accelerate the pace of research. So we're now, I headed a committee. I was on the working group, so I formed a committee that was patient-led research. And so we had somebody from long COVID, that was Lisa McCorkle. We had somebody from ME/CFS, and then I was on it, and then Liz Horn from the Lyme Biobank was on it. And it was just, I think it was a breath of fresh air for people sitting in that room. They had just never, first of all, they didn't know that patients did research. And second of all, they didn't know that patients were so enthusiastic about what they were doing that they had so much data to share. So it was an extraordinary event. And I do think we need to see more of that, because when you talk about barriers to accelerating the pace of research, some of these diseases have got things in common that aren't obvious. So, John Alcott and his group published a paper yesterday that was included in it a lot of things on neurology, and a lot about the overlap. Peter Rowe, who is involved with ME/CFS, was also on the paper. And one of the things he started talking about was small fiber neuropathy. I mean, and it's a funny thing, because that's 10 years ago, people weren't talking about small fiber neuropathy. And I remember, when I was on one of the patient panels, they now have something called the IACPAC, which is Infection-Associated Chronic Conditions Advocacy Group, right? So I'm a part of that. And one of the things they said is, and nobody's talking about small fiber neuropathy. And I remember when the woman said it, I thought, it's really a problem. And
It's funny you say that because
yeah,
there was a young girl in Colorado and somebody sent me the link for this, and she was diagnosed with small fiber neuropathy and gastroparesis with the diagnosis of long COVID. And I
yeah,
contacted her just yesterday and I said, listen, I'm not looking for business. I'm
yeah,
just here to help. I'm just letting you know if you have small fiber neuropathy with gastroparesis with autonomic dysfunction, if your
yeah.
doctors have not checked you for Lyme and co-infections, please
Uh-huh.
have your doctors do the following and please feel free to contact me. Just yesterday, I did this because it's one of those, very, very clear things you see in the chronic Lyme population all of the time. Lorraine, I'm sure people are going to have a lot of questions after they listen to this, and including, by the way, how do they enroll? And I would encourage everyone who is listening to this, we're hoping to get 50,000, 100,000 people on this summit. That would be amazing to get them all to enroll. So how do they enroll and contact you and get a lot more information and help the Lyme community?
Well, they go to MyLymeData.org to enroll. And to contact me, they would go to info@LymeDisease.org. And the process is very quick. It takes very little time to fill out. Patients who have completed the survey say, look, I was really sick. I really couldn't do much, but this was the one thing I could do. So that's why I think we've gotten 18,000. We would love to get 20,000. So I just put that number out there so that people feel inspired. It's not going to take much time. Do it while you're thinking about it.
Oh, I'm going to go even higher, Lorraine, since we're expecting 50 to 100,000 people. I'm
Yeah.
hoping everybody who watches this summit is going to go, I want to sign up, right, for Lorraine and get this. And honestly, wouldn't that be fabulous if we got another 20, 30,000 people to sign up who are listening?
Yeah, it would be enormous because these large samples allow you to look at things that you can't look at in small samples. So, like if you have a sample of 20 and you ask them a question that's got 5 choices, you're down to a sample of 5 for any one choice, right? It just, it's when you're asking deep levels of questions, sample size matters more than ever. So it's really important to sign up, and it's really important that we get the data from everybody, including patients who have acute disease, including patients who are well, and including, of course, people who have late untreated Lyme disease and people who have chronic Lyme disease. All
Right.
of those
And of course,
patients
this
will
is a
have.
way for people to take their illness, right? All the suffering and difficulties they've had and contribute to science, right? Contribute
Yeah,
to
yeah.
something that will help other people along the way so that, their journey is basically one that's going to benefit a lot more people. And it really doesn't take a lot of time, right, to fill this out and to do this.
No. It's 20 minutes. It's really no big deal. And it just contributes so much to our understanding of science. We've got 6 papers that we've published. We have 2 more that we're working on. And the list from there just goes on because you can see that every time you do a study, you see, oh, well, we haven't asked about, we haven't looked at this carefully. Let's look at, one of the things we're going to be working on is neurological Lyme.
Right.
So, Rich, I mean, a lot of the early studies on neurological Lyme, you had to have objective symptoms. But, finding objective symptoms is pretty invasive. It might involve a spinal tap, and they're extremely rare. So requiring them is like, requiring a needle in a haystack. But we see that most patients, they're complaining with persistent Lyme disease, they're complaining about neurological symptoms. Those are their worst, right?
No, and then, and in the dapsone studies that we've been publishing, because we're up to
Yeah.
8 studies we published, neurological improvement was 68%. That was the biggest
Wow.
improvement we had because dapsone's penetration into the brain is enormous. It has great CNS penetration. It's anti-inflammatory. It, works against malarial parasite. It works for autoimmunity, and it's a persister drug, right? So, I mean, we are seeing that the neurological improvement's great, but you're right. You're not going to get people with a lot of Bell's palsy showing up or, other cranial nerve palsy, which is the definition the CDC is using, right? Even the psychological issues in the paper we just published, we were
Yeah.
highlighting this. It's in peer review right now. We did
Right.
3 case studies that we just took from the last paper we published in Microorganisms. And it was really amazing, the psychological symptoms. These kids who suicide, the ones who are at risk, they're talking about it now with COVID. This is massive. I mean, this needs to be highlighted. It's such a risk for the young population that it's not just, neurology, it's psychological also. And of course, Bartonella makes it way, way worse, as does Babesia. So, let me use that as a stepping stone. The percentage of co-infections, Babesia, Microti, Duncani, Bartonella species, and even persistent Lyme, I'm curious, when you were pulling the data, how many of these people had positive PCRs, had positive fishes? Can you give me a little bit of the details, like how much you're finding in this population?
Well, yeah. So, I mean, we ask patients, have you been diagnosed with, and we, Babesia, Bartonella, Ehrlichia, Anaplasma, Mycoplasma, Rocky Mountain spotted fever. And then we ask, has your diagnosis been confirmed by a laboratory test? So that, that's about the level of detail you can get into with a patient. So because you start losing patients when you start talking about fish. They say, well, fish swims in the ocean, Right. But at any rate, with laboratory confirmed co-infections, there were 32% who reported Babesia, 28% Bartonella, Ehrlichia 15%, Anaplasma 5%, Mycoplasma 15%, and Rocky Mountain spotted fever 6%. And a lot of the patients were reporting that they had, a third, so they had 2 or more co-infections. I was one of those lucky candidates, right? And those people are, of course, harder to treat, right? Because you know this better than anybody, Rich. I mean, the agents that you're going to use to treat people with depend on what they're infected with, what this organism is going to respond to. So that's another reason why you see a lot of patients with persistent Lyme disease having co-infections. And, the CDC used to say, and I'm not sure that they do anymore, but they used to say, co-infections are rare. They're rare. They don't happen. They're rare. And, everybody kind of thought that they were rare. But when we did this survey, one of our first publications, we said, not so rare. 60% of patients with persistent Lyme disease have a co-infection. And perhaps that's the defining feature of developing persistent Lyme disease, or one of the defining features, right? And so if you're only looking at the acute population, you're not going to see those co-infections. But when you start, they may not even be tested for it, right?
Right. I mean, the Lyme docs do it. I mean, in the publications we've been finding, the Babesia for me has been around, somewhere between 66 to 80%. And the last paper we published a few months ago, Bartonella was 84%. But the interesting part was the only way we were able to find it with a lot of these species, we had to do a Bartonella immunoblot, right, to at least get those species, or had to go to Galaxy to get all the different, right? It wasn't just Bartonella henselae or Quintana or Bacilliformis. So that's the problem, of course. You got 18 different pathogenic species of BART. Right. Very difficult to know. I think a lot of the times in the earlier patients we were seeing, I think the BART patients were probably a lot higher than we realized. We just didn't have the tools to be able to diagnose it. And I think you'll find over time, as more and more patients enroll, I'm seeing the co-infection, at least, I mean, maybe it's different in my practice than others, but I think it's going to be pretty similar. It's over 50%, and we're seeing a lot higher, at least in our patient population.
Yeah, the thing is, Rich, in the survey, we say, were you diagnosed? So think about that. That means a clinician may not have asked, may not have done the test, may not have looked. Patient may have a co-infection. It's not reported in the survey because it wasn't diagnosed. Maybe nobody even suggested it, right? I mean, that's really common. I think for patients to be sick for 2 or 3 years, maybe somebody diagnoses them with Lyme, but then maybe it's 2 years later, the doctor says, well, you know what, let's do a Bartonella test.
Right. And the thing that's a little sad about Babesia is, I mean, not that everyone gets the malarial symptoms, but, day sweats, night sweats, chills, flushing. I mean, the joke I have for men when they come into my practice in their 20s and they're complaining of sweats is, I'm sorry, are you in menopause? It's
Yeah,
like,
right.
what did your doctors think? You know, you don't have malaria, you don't have hyperthyroidism,
Yeah,
you're
right,
not
right.
in menopause, you've not been to India to get this, you don't have tuberculosis or non-Hodgkin's lymphoma. It's like the basics in medicine is differential diagnosis and taking a proper history. And
Right.
taking a history in a Lyme patient and malarial symptoms, air
Um,
hunger, cough. I mean, it's
yeah,
basic. And honestly, even doing a physical exam for Bart, the more times you look for those Bartonella striae, the more
yeah,
you
right.
start finding it in these patients. And I'm not even sure the doctors are always looking for it.
Yeah, I think by and large they're not. So I mean, I think it's really unfortunate, but among physicians or clinicians who treat, the ones who are sophisticated enough to know this level of um, understanding about the disease, I think it's a handful, two handfuls, three handfuls. It's really not a lot. And so, I mean, that's partially why patients who are really sick will take the extra effort and travel to find an experienced clinician. It
Right.
just,
And
it
by the way,
really
it's the same
matters.
reason that when we publish, I try and put every detail of everything we do so any doctor can pick up the paper and say, these are the supplements he uses, these are the drugs he uses,
Right,
these
right,
are
right.
the, just so that, I'm trying to share it as much as possible. In fact, a
Yeah,
woman from Mexico contacted me on LinkedIn and said, my boss's 24-year-old daughter's sick. And I said, listen, if she's got a Mexican doctor, I can help the doctor. It's all in the paper. I mean, I'm encouraging these doctors to learn the protocols, not to come to me, but to learn the protocol so
right.
that they can get the patients better.
Right, right. I mean, that's really what has to be done. And there are some people who are doing some fabulous work in clinician education. But unfortunately, most doctors and clinicians are graduating without really any basis for understanding this or how common it is.
Mhm.
I was on a committee not long ago where people were talking about, and it's just infuriating, people from California, they were talking about, we're only going to consider endemic states. And California is not considered endemic because we have we have a really large population and we have a lot of different ecosystems. And this is a disease that's driven by ecosystems. So you take the state of Connecticut and you put it in California 14 times. Seriously, that's how large California is compared to Connecticut. And if you did that, would we be endemic? Oh yeah, we would be endemic in, numerous counties, numerous areas, right? But that's not how it's measured. And people who read guidelines without thinking will say, well, it's not an endemic area. But there was a study that came out from Fair Health a number of years ago that was published in the Wall Street Journal, and they have a vast insurance database. And when they looked at claims submitted, California was among the top 5.
Mhm.
So how can we be among the top 5 in terms of raw claims committed and not be considered an endemic state?
Of course.
It's just, and why do we need a criteria that's endemic? Why does it matter?
Even the Quest data, the Quest data that came out a couple of years ago that showed
Yeah,
the numbers jumped from like 6% to 11, 12% right over a period of time. And that was
yeah,
across the US, right? I mean, so it's definitely growing and it's getting worse. Now, let's go back to the data again a little bit. The
yeah.
worst symptoms that people showed up with in the MyLymeData registry, what were the worst symptoms on top of the list?
Well, the worst symptom by far is fatigue, which is, shared by long COVID, and it's also shared by ME/CFS. So 54% report having that. And that's followed by sleep impairment, 38%, muscle aches, 38%, joint pain, 38%, neuropathy, 34%. And then in addition, between 20 to 30% report cognitive impairment, memory loss, or psychiatric symptoms, GI complaint, headache, twitching. So, I mean, there's just the thing with symptoms is they really vary by the individual. So it does seem like some people more likely have the joint and muscle aches, and some people more likely have the neurologic. And those patients seem to be in different profiles, which is why we're looking into neurology right now, because we think it's a very big deal. And when you start looking at clusters of symptoms, what you find is the leading cluster is neurology. So you start combining things like memory loss with neuropathy and some of these other things. And pretty soon you're dealing with, large percentages of patients. In fact, the largest percentage of patients having neurological symptoms.
Mhm.
But, this is a disease that's mischaracterized across the board because the CDC takes acute patients and then they apply it to chronic patients. And it's just not the same disease. We looked at, there's a simple question you can ask, and the government asks this in a lot of their surveys. How would you rate your health currently? Would you rate it as excellent, very good, fair, or poor? And people who report that their health is fair or poor, that's really uncommon. In the normal population, that's about 16%. But, in Lyme disease, it's like in persistent Lyme disease, it's 77%.
Mhm.
Oh my goodness, these people are really, really ill. And then when you start diving in and saying, how many severe symptoms do you have? Well, a lot of patients have very severe symptoms. How does it affect your work? People have to quit work. People have to go to part-time. People have to change the nature of their work. So it has this profound effect. And then, well, how does that affect your family economically? How does that affect your community? Your community is not, collecting any taxes on income you're not earning, right? So it's affecting really everybody. And it's a problem that's not being addressed because we have this old way of looking at the disease, which is under the model of acute disease.
No, I speaking about the disability because Holly Ahern and I are both working on the New York State Tick-Borne Disease Working Group, and I looked at disability in New York State. And I was surprised to find, that the level of disability in New York State was actually in the country, by the way, it's 1 out of 2 people has one chronic disease. At least 50% of Americans suffer from one chronic disease. But I was surprised to see it's at least a third of New Yorkers,
Oh yeah, that's interesting.
We're talking disability, and when you look at what it is, it's like it's fatigue, it's arthritis, it's cognition. It's like, how do we know that all of these people in New York in a very highly endemic state have not been exposed, and all the money that the healthcare system is spending on disability payments? Again, they're not productive members of society, how it affects their family. You're right. I mean, I don't think people understand the full scope of how this is, and with the climate, the ticks are just getting worse and worse every year. And I don't think, we're taking enough precautions at this point. I know most of my patients, I tell them about prevention all the time, but you've really got to drill this home for people, because once you're sick, it's not so easy.
Yeah, I think that's right. I mean, we ask an open-ended question that's, how would you describe your current employment status? So full-time, part-time, whatever. And one of the answer choices is disabled. And the people who select disabled, it's 38%. It's remarkably high. And the point that you're making about this many people having chronic conditions, and most of these diseases that we're talking about are other conditions like long COVID or ME/CFS. They have no cure. The thing that's so frustrating about Lyme disease is there are some cures that work for some people. They don't work for everybody, but there are some cures that work for some people, and people's hands are being tied from providing those cures. So patients are remaining ill, and some patients just give up on the system.
Yeah.
Right. It's so hard to find a doctor.
No,
it's so hard to navigate insurance.
And this is why later this year, if I have the energy and I get the support, after we publish, hopefully, this next paper that went into peer review, I'm going to try and do a multi-center placebo-controlled randomized trial on dapsone combination therapy, because as you know, the last randomized trial was done by Brian in 2008. I mean, my God, it's over 15 years ago. We've had a randomized trial. And when the NIH did it, they didn't know about biofilms at the time. They didn't know about persister bacteria, persister drugs. We didn't address co-infections. And in my case, none of the MSIDS variables, right, were addressed, like POTS dysautonomia, et cetera. So we learned a lot in the last 15 years. And yet some of the agencies are just making believe like the science is the same as it was, but it's not. We've learned a lot.
Yeah.
And I think that brings up the point, since you're looking at the data, there's a lot of people who, one size fits all treatment recommendations. Can you address a little bit, how do people vary in the treatments like that they've been given by different doctors?
Well, they vary quite a bit. I mean, one of the myths that we wanted to dissolve was just this notion that you use one treatment approach and it works for everybody. And, when you look at the studies that have been done, they've been so small, 36 to 120 patients. So when you're looking at those studies, you know that they can't distinguish between people who are responding to treatment and people who are not. And let's just say you took a simple system and you said, if you respond, I'm going to give you a +1. And if you don't respond, I'll give you a -1. Well, you add those two together and you're going to come up with 0, which is no treatment effect. And that's what happens when you use treatment averages in small samples.
Mhm.
There are people who are saying that it is, that there are, as a matter of ethics, you need to size your sample large enough in order to be able to detect treatment effects that are moderate to small, that patients would consider important.
Mhm.
And that's simply not being done. So we found one of the papers that we published was about about how people vary in their treatment response. And it was one of the things that was so fun about doing it was just sort of other people who've worked in this area that aren't in Lyme disease. But, like you draw a normal curve, right? Like we're all aware of the normal curve distribution. And you take a randomized control trial and it is very selective in who gets in. So it could be at any point that it's drawing out its sample. That sample is not representative of the patients who have the disease, right? So what we found that patients were able to be categorized as treatment responders. So those were patients who said that they were moderately to a very great deal improved, and or they were capable of being characterized as well. So, those the groups, you can put them together in a category. And then you had people who were responders, but, not at a really high level, but, they were getting some success out of the treatment. That was over 50%. And then you had some people who were non-responders. And, that's important to know, because then you can go a step further and say, okay, well, if we have responders and we've got well patients, right? We got people who are really doing well. What did they do and what worked? And what we found was that those patients were using antibiotics, using them for a long period of time, over 4 months, over 12 months. And you could see, that the duration of therapy was linked to how well they were doing, how they characterized their health, with that question, excellent, very good, good, fair, poor. You could see that. The other thing you could see is, people talk about, does Lyme disease progress? And I remember asking that question very early on. Do we know that Lyme disease progresses? And the answer was nobody knows. That because nobody had done the study. Everybody knew, but we hadn't done the study, right? So when we look at patients in these various categories, you look at acute patients, and then you look at patients who are diagnosed at 6 months to 1 year, and then you look at patients who are diagnosed after that or at 10 years. And you see that this quality of life that I'm talking about, excellent, very good, good, fair, poor, just skyrockets, right? So like in acute disease, it's like people are doing pretty well. There's a percentage that report their health as being fair or poor, but most people are reporting that their health is good, very good, or excellent, right? But as you progress, you just see it goes right up a slope.
Mhm.
So, like catching this disease early, there's no more important thing that we can do. And it just seems to me that nobody's even trying. It's so frustrating.
Yeah, in the paper we just published, I have to do a PubMed search every time I'm doing this. I was
Yeah,
looking at early Lyme disease, and
yeah,
I was trying to figure out, when you look at the Wormser paper, from
Yeah.
antimicrobial agents and chemotherapy like 35 years ago,
Right.
80 to 90% responded with early. But if you looked at the 10 to 20% that didn't, it was usually because they either had peripheral nervous system symptoms, tingling, numbness, burning, stabbing in the extremities, Lyme neuropathy, right? Got into the peripheral nervous system,
Oh, that's really
or
interesting.
central nervous system,
Yeah.
light sensitivity, sound sensitivity, memory, concentration, sleep disorders, mood disorders, etc. So it had clearly either gotten up into the CNS or PNS, but then
Yeah.
I looked recently at the biofilm data and didn't realize there are biofilms that are being found in ticks in the
Uh-huh.
midgut in some of these ticks. So it's like, well, hold on. Is it possible? Because no one's looked at this. Should we be using biofilm agents? Because the reason the antibiotics aren't working in that subset who take antibiotics early on is we needed to be opening up the biofilms because the bugs are protected from day one that they're forming biofilm aggregates, not even later. No one has looked at it. We put
Yeah.
this in the last paper we just did
Yeah.
because I thought, wow, that's something somebody's got to look at.
Yeah.
So yeah, and there's a lot of data I know we can pull out. And by the way, these people that did well on long term, I'm obviously trying to create protocols now that are not long term. The
Yeah.
the Dapsone protocol is 9 weeks followed by 2 week pulses, and we are having success, but I need to prove it to the world in a randomized trial. Did you pull out of the data the people who were doing well on long term, and then
Yeah.
they stopped the treatment, and they were
Yeah.
not on persistor drugs?
Yeah.
They were on a cell wall drug like Ceftin or Omnicef or a penicillin or whatever.
We're almost all on doxycycline, just FYI.
Okay. So did it show that the relapses were happening when they stopped the antibiotics, even if they were on long term?
No, this is a really interesting question. I think it's interesting. I consider myself well, and there are people who say nobody can be cured of Lyme disease. I don't consider myself to be completely free of all symptoms, but I consider myself well at this point. And what surprised me is we ask the question casually, are you sick or are you well? And we have like 1,000 people who consider themselves well in our registry, which is phenomenal, right? Like, where do you find those
But
people?
that's only 1,000 out of 18,000 in the
Yeah,
registry.
but we aren't even trying to get people who are well to register. See,
Oh, I see. Okay.
everything we're doing is geared towards people with chronic Lyme. So to us, it's kind of like, oh, really? We got that large a sample for that. But we do ask those people, were you treated with a common course of antibiotics? Did that work? What did your clinician do afterwards? And how did you respond? So, for that early piece where it's like, okay, 30 days and then no treatment, did you relapse or did you come back? We do ask it there. And we haven't analyzed that data. I mean, it's an example of, we're drowning in data. We have a ton of data to analyze. And that's one of the things we want to get to, but we haven't gotten to yet.
So you can't just put in your phone Chat GPT and just say, "Can you please go on the site and tell me the answer to this question?"
It's real interesting, Rich. We are working with artificial intelligence. We have been working with artificial intelligence since we launched the registry in 2015. So that is kind of remarkable, right? Because right now is the heyday of AI, but we've been working in it since 2015. So we have a great partner at UCLA, Dr. Deanna Needell.
Mhm.
And we have just learned an extraordinary amount. So what AI is really good at is taking vast quantities of information and saying, looky here. That's what it's really good at. And then you go in and you look and at that particular item and you say, okay, well, what is it about this item that AI is telling us? They're telling us is important, but why? Because you still have to apply common sense, right? If you don't have common sense, AI it's not useful. So, we've seen it used in situations where, oh boy, they really needed to have somebody who knew something about the disease involved. So yeah, so we're lucky with our studies. We always have a clinician, we have a biostatistician, we have an academic researcher. I mean, that's, and then we've got, I'm involved. So we have a really great team of people who've worked together now for a very long time. I'm feeling really, really fortunate about that.
Yeah.
And I just want to
Right,
say one thing, Rich.
I just want to dive in because we've got
Yeah.
about 10 minutes left. I want to make
Okay.
sure I get these questions in. Tell me
Okay.
about alternative therapies. What did you pull out of the data? Because a lot of people, I think, have questions on the efficacy of alternative therapies. What have you found?
Well, so we had a set number of different alternative therapies that we considered, something like 15. And we asked patients which ones were effective, how effective they were, and whether they had side effects. And that was a really interesting question to have asked, because the top ones that were identified are ones that you would suspect. They were the herbal protocols, a lot of which are antimicrobial and might address the bugs, right? So they might actually, the mechanism by which they're working may be that they're targeting, critters that shouldn't be in your blood or shouldn't be in your tissues. But the other thing, and then sauna comes next. Okay, so I mean, sauna's got a really long history of being effective for many, many, many things, in terms of how it works with the immune system and what it allows the human body to do by recovering, by detoxing, and by just improving the immune system. So that one's not a surprise. The one that was surprising to us is we asked at the time, stem cell therapy was very, very popular.
Mm.
And so we asked about stem cell therapy. And we were just shocked that we got 300 people at that. And this was early on. So we had about 2,000 people who had enrolled. So 300 people had tried stem cell therapy, and only 3% said it was effective.
Mhm.
So, there's a lot of different ways they do stem cell. It could have had to have done with that. But, when patients see that, they say, okay, so 60% are saying that they're improving on antimicrobials, and 3% are saying they're improving on stem cell. I got to make choices. I think I'm going to go on antimicrobials. And, a lot of patients can't get antibiotics, period. So the treatment they can get is an antimicrobial. So we have, the samples for antimicrobial herbal treatments are really pretty big.
Mhm. Great. And what about the difference between men and women as far as treatment response, severity of illness, persistent Lyme disease? Can you talk a little bit about sex differences?
Oh yeah, that was very interesting. So we decided to do a study of the difference between men and women in persistent Lyme disease primarily, and we compared it with acute. But what we found was that women reported more tick-borne co-infections, worse symptoms, longer diagnostic delays, more misdiagnoses, and worse functional impairment than men. And there were no differences reported in antibiotic treatment response, which I thought was interesting.
Mhm.
And then we took the broader lens, right? Because a lot of studies have been done, including your studies, right? We have studies by clinicians who are using different criteria for enrollment. We have randomized control trials that the NIH funded. And then we have studies, that are larger databases. So MyLymeData, we've also got the Lyme Biobank. They have really expansive entry criteria. Anybody can get in if you've been clinically diagnosed, essentially. And so what you see when you look at those categories is you see that with acute disease, so studies of acute disease showed that women were, pretty much on par with men. There was a slight difference. It wasn't great. But then with persistent Lyme disease, if you were looking at a randomized control trial, it went up quite a bit. But then if you were looking at a trial that was done by a clinician, or that what I would call real world data, so a clinician, a patient registry, or a Lyme Biobank, it went up enormously, right? So it does seem that women are contracting more persistent Lyme disease. If I had to take a guess as to why that might be, because there's a lot of reasons it could be, right? It could be hormones, it could be biology. Women really are different than men on so many levels, and they react to different.
That's a whole nother hour talk that we could be doing on this one, by the
I
way.
know. I mean, it's so interesting because people have always just put them together as one group and really only done the studies on the men. And so then they apply them to the women and then find out that they're not true. So women were having heart attacks, when we knew how to treat men, but we didn't know how to diagnose women. But I really think it has a lot of it to the extent you can control it. I think a lot of it has to do with misdiagnosis, diagnostic delays. Women are gaslit all the time. When
This is the usual. The women goes in and they think, oh dear, it's in your head. You're just stressed at home with your children. Don't worry, right? You think that's probably playing a big part. And by the way, when women have come in and told me that they've said it was in their head, my usual response is, well, it is in your head. You've got spirochetes in your head. You've got toxins in your head. It's like, oh, he was right, just not for the right reason of why they told it to you. But honestly, in this day and age, it's beyond the beyond for me that there's still those kind of sexism differences at this point in time. It amazes me.
Well, I think it's really large, there's a lot of advice includes things like bring a man with you to your appointment. So you bring your husband or your spouse or your partner or a friend, and they could say, yeah, I've seen this. It's just this credibility issue. So, it's the same thing, Rich, with, self-reported data versus clinician-reported data. So if I say something to you and you write it down, suddenly it's good. It's good information. It's clinical information. But if I say it directly, if it's self-reported, oh, it's questionable. It's questionable. May not be true. She may not understand her symptoms or, their severity or, whatever.
Right.
You can discount the individual, but, and that just, unfortunately, that happens a lot more with women.
Yeah. So let's just finish up because we only got a couple more minutes. So Lyme disease comparing to other diseases out there with severity. What did you find with the data? Because usually we hear like it's as severe as chronic congestive heart failure, right? I mean, this has been reported in the literature, even by other researchers. You finding that in the data? Like that's how severe people are?
That's how severe it is. I mean, it's kind of staggering because, that simple question that I told you, which is, how would you in general report your health? Are you excellent, very good, fair, or poor? That simple question, many diseases use it. The government has used it in many surveys. So in general, in the population, it's 16% are reporting their status as being fair or poor. With persistent Lyme disease, it's 77%. And that's higher than other chronic illnesses also. So for instance, it's higher than lupus, higher than multiple sclerosis, higher than congestive heart failure, and higher than fibromyalgia. So it's hard to find a disease that's got a greater amount of people reporting their health status that poorly. And, as I said before, that progresses. As the disease progresses, people report more poor or less health status. I mean, less quality of life.
Yeah.
So they also report more severe symptoms. So you'll see them going from, this is staggering. Patients on average are reporting 3 severe symptoms. That's a lot of severe symptoms to be dealing with, right? But, patients who have fair or poor health status, well, they're reporting 4 or more severe symptoms. So these people, are really, have a large severity of symptom load, and it's going to affect whether they can work. It's going to affect how often they go see doctors. They see doctors 5 times as often as, other patients, the general population. And they're more likely to be hospitalized, 2 times more likely to be hospitalized than the general population over a year. So, it's like we discount these things. We say, oh, this is the yuppie flu. This is not the yuppie flu,
Yeah. This is a very severe disease, and it's all across all stratums of society and age and sex. And I mean, it's just terrible. So listen, believe it or not, this was an hour conversation that we've hit. So we're kind of out of time. So I just want to finish up with people and say, for those of you listening, I would encourage everyone who is coming to this Lyme Summit, please contact Lorraine and MyLymeData and get your information. As you heard earlier today, it does not take that long. It's 25 minutes to fill out these questionnaires and get your data into the big data so you can help other people. Lorraine, again, as we're finishing up, tell people how they can contact you, MyLymeData, and anything you're working on in the future that we can expect, some great research, just like all the great stuff you've been putting out.
So if you want to enroll in MyLymeData, go to MyLymeData.org. It's all one word, MyLymeData.org. If you want to contact me, send an email to info@lymedisease.org. And we'll be sure that we get right back to you. We would really love to see these numbers. 18,000 is a lot, but as Rich was saying, it can be a lot more. Let's make it a lot more.
We can aim for the sky and just kind of see what happens. But as I said, I think we're going to have a great turnout during the summit. So, I mean, we'll see what the figures are. But so again, everyone, I just want to thank you so much for attending the summit. You've been hearing from myself and Lorraine Johnson of patient-led research and MyLymeData, really the only big data set that's out there. And again, I encourage people to please contact Lorraine and get your information in there. Again, my name is Dr. Richard Horowitz. I've been co-host for the Healing from Lyme Summit from Doctors Talks. Thank you, everyone, for attending the summit. It's been great. We've got a lot of great information, and we look forward to seeing you also soon. Please look forward for another episode. Thank you so much.